Hello, everyone. Welcome. As you come in to the webinar, we're going to give folks a few more minutes to get on. So just sit tight for a few moments and then we'll go ahead and get started. And for those who have just come in, we're just going to give everybody a few more minutes to get into the webinar, and we'll get started in about 2 minutes. But thank you all for joining us today. We're very excited for this conversation.
Okay, in the interest of time, I see it's just a couple minutes past 2, so maybe we'll go ahead and get started as folks continue to trickle in. I'm Allie Kaur. I'm a health scientist in the Division of STD Prevention at CDC and part of the UTASP for Using Technology to Advance STI Prevention Workgroup. And myself, along with our NCSD colleagues, are excited to announce our second National Internet Partner Services call this year. Next slide, please. Today, we have 2 really great speakers, and we're really excited for what they have to share. First, we'll be hearing from Jen Hecht from Building Healthy Online Communities, and she'll be talking about the TakeMeHome HIV Home Testing program. And then we have Bryan Collins from the Virginia Department of Health, who will be talking about Virginia and Maryland's home HIV testing program. We'll save all the questions for the end of the call, but as they come up, feel free to put them in the chat, and then we'll get to them after we are done with our speakers, and then open the mic for any other exciting topics we wish to discuss. So without further ado, I'll turn it over to Jen.
Unmuting now. Thank you for the invitation to join you. I'm gonna start my screen share, so give me a second while I get that all set up. All right, thumbs up if you can see it, the slides. All right, awesome, thank you. Great, so again, thanks for the invitation to join you all here. I'm gonna be talking about our home testing program, TakeMeHome, that is created and developed by Building Healthy Online Communities and working in partnership with both NASDAD and Emory. Just for a quick second, I think it's helpful to talk about who BHOC is, what we do, and who we partner with. So Building Healthy Online Communities was established in 2014. The idea was to really think about how various different public health groups could be working in partnership with dating apps to really think about leveraging those relationships and making sure that we're working closely. You can see many of the apps that we've worked with here. And just to give you an example, we work on many different projects with the apps. We're very interested in sustainable changes to the apps that enable folks to be able to share and gather information from users, from other app users. So that might include making sure profile fields have options to say, for example, I'm on PrEP or I'm positive and undetectable, those kinds of things. We've worked closely with many apps on that. But we've also worked on a number of other topics, including sexual health resource information and making sure that app users have access to many different sexual health resources. So how did we come to focusing on home testing? We've done a bunch of formative research and work in partnership with Emory with dating app users. And what we saw was there was a very high proportion of MSM on dating apps who reported that they'd never tested for HIV. And likewise, we saw that a lot of app users were really interested in being able to order a home test kit through an app, or through finding out about it through an app. So that's what led us into this work. And so the TakeMeHome platform was built and created and launched in March of 2020. Now, you might also note that date, of course, coincided with when we really saw a pickup of COVID here in the US. That was completely fortuitous, or, it just happened to be that way. I mean, we'd been working on it already for quite some time. This platform enables a centralized system for HIV and STI test kit ordering, distribution, and results. We partner with various different public health departments as well as community-based organizations in order to fund and create access for HIV and STI test kits. And then our strong partnerships and relationships with the apps enable us to reach and engage app users to promote testing. So the kits are free to users and they're paid for by our participating health partners. So this is what it looks like on a phone. We've done our absolute best to make this process as simple as possible for users. We specifically were setting out to reach users who hadn't already tested or hadn't tested recently. And we did a lot of user research, and what we heard from users was that some of their concerns were that they didn't know where to go to get tested, that at more traditional testing sites or community-based testing sites, they were concerned that they would that they were experiencing stigma or discrimination, that their experience was that it wasn't private. And again, these are perceptions and concerns, but they're real and they were affecting people's ability to access testing. So the things that we focused on were making it free, making it easy, and making it discreet. We have basically 4 eligibility questions for users, and then they will find out if they're eligible. They put in their name and address, and they can order a kit. The process is somewhat different between the oral rapid test, which is the Aura quick test, and the STI test kit, which I'll get into in just a moment. But what I think is helpful to know here is that we really built this with the idea that as many jurisdictions as want to participate can. So it's a really straightforward process to join us. And the reason we kind of came up with this model was to recognize, first of all, this is how public health funding works. It's, it runs through the states, it runs through the counties. But we also realize it's a lot of work to build this kind of system. So rather than say, well, each jurisdiction build their own, we really were thinking about how can we build this once and then invite as many jurisdictions as want to participate in it. We really do a lot of work to try to make that as easy as possible and to also be able to tailor. So there are opportunities to tailor eligibility based on the specific needs in each jurisdiction. And we're also able to target promotion. So what that means is if there's certain areas that a jurisdiction wants to do more or less promotion, we have a lot of control over that in terms of both eligibility as well as where ads and messages on the apps run. We can, for example, we're not spending a lot of time, promoting in areas that are not a part of the program. So the HIV Oral Kit program, as I said, is very, that's the simpler version, right? So a user would, answer these few eligibility questions. They would put in their name and address. They'd order a kit. They're going to get prompted to answer a handful of additional questions. And then 10 days later, they'll get a follow-up survey. Since we launched in March of 2020, so about a year and a half, we've put out over 8,000 kits. And we started out with 4 health jurisdictions. Actually, we're now at about, I think, 20 or 21. What I think I'm most excited about from this project is that a third of users reported that they'd never tested before. So we really are reaching the folks who weren't otherwise accessing these services. We've had really positive user feedback, and I think there's sort of a sense of relief, like, oh, here's a way I can do this for myself at home. And our goal here is also to be able to build trust and credibility with the public health system. So we see this as kind of an entry point for folks who've just never really felt ready to go in to get a test. We also know that, with the HIV oral rapid test, someone's going to get their result at home, and they may or may not be able to or choose to share that result with the health department. So there is a way to help do that, which is through surveillance matches. So every month with our participating partners, we will send them a set of data of kind of who ordered the kits, and then they, if they have the capacity, can match through their surveillance matches. I want to be really clear that when users order from us, that's part of the consent process. We let them know that whoever paid for the kit is going to get that data. And we're, of course, very careful with how that data is shared. So briefly, I want to share information about kind of who's participating in our program. We're seeing that about 50% or more of participants are under age 30. And you can see at about 50% or so of participants identify as people of color. What I will note is that the demographics of participants continues to keep evolving as we add on different sites, because the background demographics in those areas are dramatically different. So we added a bunch of counties in Southern California. We saw an increase in Latinx participants, for example. So I think that's important to note. And we have translated the site fully into Spanish. So all collateral, all materials, emails, et cetera, are in both English and Spanish. Here you can see kind of where the kits are going out across the US. This is based on the 20 participating locations. And finally, I want to talk a little bit here about promotion. So this is a huge part of our model, and it's built in from the very beginning in terms of our relationships with the dating apps. So you can see, here's an example of a message coming from Grindr to their app users saying, this is a way to get a kit. But we also develop a lot of our own materials, and we encourage health departments and participating health partners to do their own promotion. So we will give digital assets and files to our partners, encourage them to place those on social media. We send out a post of the month to kind of create different messages, different images, and really kind of support the partners to be able to promote in other parts of their community as well. One of the fun things about this job is getting to partner with some, I'll say, non-traditional partners. So this is a partnership with men.com, which is a porn site. When we told them about our work, they were really excited about it. And they were like, we can lend you some talent. And so they made us a video. We wrote the script. Their talent, were able to make these videos for us. And this helps us get the word again into communities in a different way. This is an example of another app that's Sniffies that's been putting out some messages for us as well. So I want to just briefly talk here about the lab-based testing, because that is a very different process. So for lab-based testing, health departments can decide which packages they want to offer. And there's 3 major packages. One is an HIV dried blood spot test only. The other is a comprehensive STI test, which is going to include 3-site chlamydia, gonorrhea, syphilis, HIV, and HCV dependent on risk eligibility. And then the third is a PrEP monitoring, which is HIV dry blood spot and creatinine. So depending on the location of where the user comes in, they're going to see a different set of packages as to what's available for them. In this scenario, the users, in addition to those handful of eligibility questions, are going to be prompted to create an account. They then are going to, when they receive a kit in the mail, they will collect the specimens, they'll mail it into the lab, and they'll return to the portal for results. So again, this is still free to the user. It's postage paid. We have come up with some systems to keep prices down. So health departments are not charged unless the lab is actually processed. So they're not charged for any labs that are not processed. In this scenario, the health departments do provide medical oversight. So they have to have an NP or an MD who's sort of signed up as a point person. and they can receive, full electronic lab reporting. The health departments will get the full set of results. So as I mentioned, these are the 3 main packages that are available for health departments to offer to users in their areas. And so just some preliminary results. So we launched the lab-based component in January of this year. So it's been about 7-8 months now. And we've had 150 kits in the first 7 months that were both shipped and resulted. So there's some, of course, that are still out waiting to be returned. The average time from placing the order to getting the results was 17 days. But what's really important to recognize here is that that range was 5 days to 46 days. So if someone is ready to go, they're going to get that in 5 to 7 days. What we sometimes see is that someone orders a kit and then hides it under their bed or somewhere, for some period of time, and then decides to return it. So that's why you see those longer time periods. We've actually set a cap, so it can't be out for more than 60 days, and we make it clear to participants that they must, return it within that time period, or the labs won't be run. And when, of course, we encourage users to just, collect the specimens as soon as you get it, mail it in. That's definitely the best way to do it, and that we encourage users also to only test what they need to test. So if you use it, swab it. We've had 23 positive cases, and so across any STIs, that's a 15% positivity rate. And you can see the breakout here by different STIs. In terms of kit returns, this is a bit hard for us to gather because of that 60-day lag and time period where kits could be out and not yet returned, but we're seeing rates in the range of 60%, which compared to some other programs of this nature were, they were finding 40 to 50%. So we're pleased with this so far. And then finally, I just wanted to acknowledge some different implementation models. So as I said, like our biggest focus with this project is that we have sort of built into the model ways to promote through apps and bring in a different group of people who aren't necessarily otherwise accessing testing. And so that we would consider our traditional model. It's focused on reaching new individuals. However, we are aware that clinics can use this model to reduce clinic traffic. One of the organizations that I worked for a very long time, San Francisco AIDS Foundation, they're using that model, and they're really also actually kind of doing the navigator model, which is folks who kind of already have a relationship with a clinic can work with the user. Maybe that participant wasn't able to come into the clinic, and so they're going to order on behalf of that person, and then they're going to walk them through the process from beginning to end. But I also want to talk about a DIS model because I think that this really fits in well with the work that DIS do. I can imagine many situations in which you have a positive, index case that you're trying to reach those contacts. Either you're unable to reach them, or those contacts are not following up for testing. And so being able to then send those contacts a link for where to order a test could make a lot of sense. So I'm definitely interested in talking about that more and kind of thinking about what that looks like. Finally, just this past Friday, we were really excited that this program was highlighted in the MMWR and really just kind of bringing attention to the fact that it has effectively reached a whole lot of new people who weren't otherwise testing for HIV. And I just want to thank you for your time. Hopefully I've answered a lot of your questions preemptively, but I know we'll be having a Q&A at the end. So I encourage you to stick around for that, and also feel free to reach out to me if you have any additional questions. Thank you so much for your time.
Hey, Jen, thank there was actually, one, Bryan had his hand up, and there was one question in the question answer, so I figured I would ask that now. But Bryan, did you want to say something?
No, I apologize. That was just a Zoom error.
Okay, just checking. So we will get to you in 1 second. So Jen,
yeah.
The question is, how is the at-home syphilis testing done? Dried blood spot with finger stick, how accurate are those syphilis results?
Great. Actually, thank you for that question. And I apologize, I did not take that on in the presentation because it is actually pretty a little bit complex. So first thing is, yes, it is a dried blood spot and it is going to be a syphilis antibody test. So what we've done, we're working with the lab to identify additional processes and technologies. But the reality is that with the technologies that are available right now, with the lab that we're working with, this is the best that we can offer without a lot of complications. So for example, so what we've added and what we had from the beginning was we ask users who are doing the STI testing a couple of upfront screening questions. If they're symptomatic, we're not going to test them. We're going to encourage them to go to a clinic. And we ask whether they had a previous diagnosis for syphilis. Right now, what we're doing is, and again, this is based on feedback from our participating health departments. If they say, yes, they've had a previous diagnosis for syphilis, we will not run that antibody test because we know it's going to come back positive and then it's just going to require additional work and follow up for everyone. So we're going to really encourage folks to get some clinic-based testing for that and additional follow-up care. The options that are available right now to do follow-up testing require not just the finger stick on the dry blood spot card, but creating or collecting a lot more blood, putting in a tiny little vial and sending that in. And there's so many, it's so error prone that it's really not worth it for anyone to go through that. But meanwhile, we do know that the labs are really working on creating some new technologies. We don't know when those will be available, but as soon as they are, we'll be ready to kind of make that easier. And we definitely look forward to that.
Thank you. And there are a couple more questions, but I'll hold those now to the end. They just popped up.
Great.
Okay. So stay tuned. Bryan, okay, good. Here's the agenda. The slide is coming up. So next we will have Bryan, who is from the Virginia Department of Health, but he will be speaking about the Virginia and Maryland home HIV testing program. So the floor is yours, Bryan.
Hi, everyone. Thanks for the invitation to speak on the call. I really appreciate the opportunity to talk about our program. As Janine mentioned, our program serves both Virginia and Maryland residents as part of an interagency agreement. We first began our program in 2015 and then expanded to include Maryland about midway through 2018. Prior to Maryland joining our program, kind of the basis for the Virginia Department of Health pursuing HIV self-testing was the fact that although we have about 185 test sites spread throughout the state, the vast majority of them are local health departments, and non-health department HIV testing is mostly available in metropolitan areas or in clinical settings. And Virginia is, it's not the largest state in the world, but it's a somewhat large state, which means that we had quite a wide area of clients who had limited access to HIV testing because of geography or, the distance to the closest HIV test site, or especially given the overlapping epidemic of poverty that might have been sort of excluded from the traditional HIV testing model because the local health departments or test sites in their area only offered testing hours when they had to work because they were, working in retail jobs or what have you, and weren't able to get off work to get tested. And in addition, especially in the more rural areas of our state, we've observed for quite a long time, I'm sure most people on the call are familiar with the idea that the clients that were, expending the most effort to try to reach tend to be marginalized or experience stigma. So HIV self-tests seem to serve both of those purposes. It would give us an opportunity to reach clients who might not be testing at other test sites and also offer a way to get expanded access to testing to people who might have other structural barriers that prevented them from getting tested at a more standard test site. Next slide, please. So the Virginia and subsequently Virginia and Maryland home HIV testing program is what we came up with. This program is run entirely out of our central office in Richmond, Virginia. And I have found, although I will admit that I'm a biased observer since I run the program, but I found that model of having one centralized location that tests go out of really benefits the model that we are working with, which is entirely electronic. and has helped us build intra-agency collaboration between the different parts of our division and our work office, as well as interagency collaboration between other state agencies in Virginia, as well as other, state jurisdictions, which is, and I refer to Maryland, which has really been a fantastic partner to work with throughout this whole process. And our program has, since its inception, had robust support from our agency leadership, which I think has really benefited the program because it's given us the ability to be flexible and to, I think, be a little bit ambitious about the enhancements that we've tried to make to the program over time. I mentioned our program is entirely electronic. We're currently using REDCap for data collection. We have a public-facing survey link that's available in both English and Spanish. Our pre-test survey collects demographic, risk information, and contact information for clients. And then clients who receive a HIV self-test receive a post-test survey by email 14 days afterwards with several reminders baked in case they don't take it the first time they receive it. And then clients who disclose a positive result or who disclose that they had trouble interpreting their result or haven't taken it yet can opt to receive coordination for further testing if they haven't already received it. Next slide. So these are just a quick rundown of the data elements that our pre-test survey and post-test survey collect. And I think that this was the amount of data or the granularity of the data that we collect, I think was a boon to our program early on, because many of these elements are not collected, or they're pieces of information that we weren't able to get in quite the same level of granularity for our traditional HIV testing program. So it really gave us the ability to demonstrate that we were seeing clients who had the type of risk that we were looking to target, or that had not been tested in quite a long time and would benefit from expanded testing. Our post-test survey also asks, in addition to the test result, how long the person waited before using the test and how long they anticipate waiting before the next time they use their next test. And we've tried to use that as an internal metric to determine whether or not our program is making an impact on the frequency of HIV testing that people actually observe in their own lives. Next slide, please. So this is a quick rundown on just how the program actually works. This is a frequent question that we get when we talk to other health departments, especially in the sort of early stages of COVID, when a lot of jurisdictions that had been interested but had not really had the political will or the human resources to devote to establishing a new project were trying to figure out how to get testing out to their communities. So our program is a bit decentralized within our central office. It breaks down across a couple different work teams, which I think has given us the ability to really scale in response to increased demand, and has allowed us throughout the entire program and all of the expansion that I'll get into to make sure that everyone who requests a test, that their order goes out the same day, or I should say the day after they place it. So every morning our program staff, would be myself or one of my two backups, process requests individually. And it's a manual process that is usually pretty quick, but sometimes can be a little bit involved when it comes to identifying potential duplicates, or clients who may have changed their name because they got married using an alias, something that would take a little bit of human effort to try to figure out if this is the same person that we're seeing, so that we can keep an accurate roll of the clients that use our program. And our program staff also generate shipping labels for clients using a software program called Indicia Professional. We use the United States Postal Service's regional rate shipping program, which you can see the box for in the image just on the side of that slide. This has really been a sustainable way for us to make sure that our costs remain consistent, and also provides us a little bit of additional integrity to the test kit. In the early stages of our program, we would just wrap the kit in brown paper and send it out, and then occasionally we would see one returned where it had been in the rain and paper had fallen off and it was just not very good. So the additional integrity of the package has been great, as well as the opportunity and the space to provide additional materials like PrEP, educational materials, condoms, lubricant, etc. Our hotline team is responsible for assembling the materials that are associated and which go out with the test kit, the collateral materials, if you will, that Jen referred to. And they also ensure just continued availability of our regional resource labels that get applied to the front of every home test kit. They also just kind of generally speaking, manage the availability of a good number of the materials that we use in the course of running our program. And then finally, our mailroom team assembles our boxes, packages everything, and is responsible for communicating with the state mail service. They've also been integral in helping us kind of sort out different mailing solutions as challenges have come up in our program. And they have been a really great partner as we've tried to figure out even get something like getting the availability of the regional rate boxes, which can sometimes be surprisingly difficult to procure. Next slide, please. So I wanted to focus a little bit on the data that we've seen in our program. And as it happens, our agreement year with Maryland runs from September to August. So we actually just concluded the third year of our interagency agreement with the Maryland Department of Health. So I actually have somewhat timely data on that front. And I just wanted to highlight the growth that we've experienced over the last 3 years of the program. You can see in between years 1 and 2, the program was growing organically because of promotion, returning clients, that sort of thing. And then in 2020, especially the latter half of 2020, when it kind of became clear that COVID was sticking around, we saw just an explosion in interest. Our program volume has increased over 250% in the last 3 years. And a lot of that, like I said, is due to COVID. But one thing that I'm personally satisfied by is that we continue to see a growing share of clients use our program, often having heard about it through word of mouth, and then make it a consistent way that they get, that they learn about their HIV status on a regular basis. So every year we see an expanded share of clients who join the kind of returning clients group. Throughout, I think one thing that we've also seen, especially over the last year and a half, is that there's been a huge increase in interest from Maryland residents. The Virginia numbers have grown, but I think as was interestingly kind of the case in the early days of our original pilot program back in 2015, there's a period of time where people don't really know what the program is or how to access it. And then you sort of see the numbers kind of organically grow over time, which is really a joy to kind of observe over this period of a few years. Next slide, please. So this is a bit of demographic and risk data about our most recent year that just ended at the end of August. And you can see that there's some variation between Virginia and Maryland in terms of race and ethnicity and gender, which I attribute to how the kits are distributed throughout the states. In Virginia, we tend to have a somewhat even distribution to all 5 of our regions, which means that we have got a more or less even number of kits going to our highly populated central, northern, and eastern regions, as well as to our more rural northwest and southwest regions. Whereas in Maryland, historically over the past year or 2, our kits have been heavily concentrated in suburban Maryland, in the DC suburbs, and then in Baltimore. We also see somewhat less than the majority at this point of our clients beneath age 30. Our program demographic continues to age a little bit, which I'm interested in trying to see if we can change in the next year or so with promotions. But one thing that I try to keep stock of is the fact that we've got a good number of clients at this point who've been using the program for 5 years. And so they have just aged up to an older demographic themselves. We've also seen recent drops in the percentage of our clients that are uninsured, which I attribute to Medicaid expansion in the period just before COVID-19 hit. Next slide, please. And then you can see here a little bit more granular data about the priority populations that we're serving and information about PrEP awareness. I apologize for the slide being somewhat busy. One thing that I have noticed, is especially over the last year, as COVID has really fundamentally changed the population of clients that are accessing the program, is a huge shift towards heterosexual clients accessing the program. And I think that that's really changed the percentage or the frequency with which people have been getting tested for HIV and the awareness of PrEP. So if this presentation had been done a year ago, you'd be looking about 85, 87% MSM. You can see that now we're serving a large minority of heterosexual clients. And that I think this is the first presentation I've given where the percentage of clients who have been tested more recently than a year ago is the majority. In the past, the majority of our clients have not been tested in more than a year or have never been tested. And as Jen acknowledged that they're finding in their program, we're also seeing clients acknowledge pretty high rates of previous STD diagnosis. But although this is historical, not what we're finding through active STI testing. Next slide, please. So this is a breakdown of positivity rate and linkage to care. I just want to acknowledge that the numbers look a little bit different here because this is from our 2020 annual report. So this is calendar year 2020. That being said, you'll note that the overall positivity rate for our program in 2020 was 0.6%. And that the percent of clients who were linked to care within 30 days fell just short of the national average, which I think is a little bit remarkable considering that all of this program is run entirely electronically. So these are clients who, in many cases, had not been frequent recipients of HIV testing that upon receiving their self-test result are able to link to care fairly quickly, thanks in part to all of the work that we've been doing to expand and simplify the process of getting linked to care in Virginia as well as in Maryland over the past 5 years of PS 18-1802. I did just want to say also, even though we have not run our surveillance match for Virginia for the September to August period that I was just presenting the data for, the Maryland Department of Health has matched their client base against EHARS for that period. And they found that between September of last year and just the end of this past August, they had 13 total positive clients, although about 10 of those were previous diagnoses and 3 were new diagnoses. All 3 of the new positives were linked to care within 30 days. And which I thought was most notable, 2 of the 3 were diagnosed with AIDS at the time of their initial HIV diagnosis. So I think even though we have seen the population of clients who accesses this type of program shift within our own program, the people who are testing positive, it seems, are still people who had not been tested for some time. Next slide, please. Finally, I just wanted to touch on a couple recent program enhancements, which all went into effect on September 7th, so earlier this month. We now have Narcan kits available to Virginia clients through an agreement with our central pharmacy. They're able to dispense Narcan on demand and ship through UPS in a separate package. And we're currently working with the Maryland Department of Health's harm reduction program to set up a parallel process for clients in Maryland to request Narcan, although it will come through, not through Virginia Central Pharmacy, but through a program that already exists in Maryland. We're also piloting gonorrhea and chlamydia self-collection kits with Binks Health. We're not sure what's going to happen after that pilot concludes, given the rumblings from the FDA about whether or not self-collection kits are allowed or not, which hopefully doesn't produce a major disruption. So far, we are finding the kind of a similar percentage of clients who we send kits out versus return them, although we've yet to see any positives come through through that program, that pilot. And then finally, folks on the call may be familiar with Unite Us, which is a platform that works with state jurisdictions to network social service providers and help facilitate referrals for clients between them. So we've set up a program with Unite Us, which allows clients to identify that they need additional social services, at which point they're sent an assistance request form, which they electronically complete, and then will populate an email to us letting us know that a client needs social services. And then our program staff will work to identify and send referrals to local providers in the client's jurisdiction through the virtual platform. So I gave a presentation on our program several months ago where a number of these were still just kind of in the offing. So I find it very kind of personally satisfying to see our program expand from a safety net to make sure that people were able to maintain awareness of their HIV status to now be able to provide kind of an expanded selection of resources so that the program doesn't feel like it's only a safety net anymore. And I really I think that that's the direction that I'm going to try to push our program in over the next few years. And next slide, and this is my contact information. So I thank you guys for the opportunity to present, and I'm happy to take any questions.
And we do have some questions. Thank you, Bryan and Jen. Before I get to the questions, I just want to give a plug that if your program, whether you're a community organization, a private agency, a health department, if you have an innovative practice that you'd like to also present related to technology and partner services, please let one of us know. And also if you have a challenge or a concern or something that you're interested in related to these topics, also let us know. And we would be happy to arrange a future webinar based on what you're interested in knowing or presenting. Okay, so I'm going to get to the questions, and the first couple are for Jen because they were asked before Bryan got started, and then I have some for Bryan as well. Okay, this is a finance related question. How do the finances work? Do groups buy membership packages or pay per service?
Yeah, great. Thank you. So we work in partnership with NASDAD on this project, and they are handling all of the contractual and payment mechanisms. But the quick answer is that in terms of the Oral Kits, the health departments or community-based organization pays for a set number of kits up front. Those kits then go into the inventory, and as long as they are available until they are used, and then they're of course able to order additional kits. We have worked with OraSure where possible to try to get some discounts, so we've been able to get some free kits through that. But certainly the pricing is always a big concern. And we've bundled our pricing. So the pricing includes the cost of the kit itself, the cost of the shipping and fulfillment, and then, sort of included in that, we also have administrative costs, small administrative costs, and then the in-kind messaging that we're able to get from the app. So that is $46 per kit for that full bundle. And that covers sort of, again, the soup to nuts. What's important, and I think an important distinction between the model that Bryan described and the TakeMeHome model, is that all of the shipping and inventory, all of that fulfillment happens with a third-party partner. So there's no staffing required on the part of the health department. So it's a very different model in terms of how that works.
And someone just asked this, I think it's sort of a follow-up to that. If kits expire before they are used, does the agency or the Department of Health have to buy more kits?
So we do track the expiration date, but essentially what we see is that most of the kits have an expiration date that's about 2 years out, and that just has not been an issue at all because we have, we're moving inventory. But also it's very easy for us to kind of just make sure that the inventory moves. So that's not a problem.
Okay, and I wanted to mention too, if someone wants to ask a question themselves, if you click raise hand, you can ask that way, and you can continue to put questions in the chat or Q&A box. Okay, so another question for you, Jen, is if someone tells you that they are a contact or have been exposed, will you test them?
Yeah, so that doesn't really come up in the way our model works because the person is coming directly to order a kit for themselves. I think when I was describing a possible DIS model, that would be kind of a way that health department might choose to implement it, in which case they would have information about that contact and then potentially would be able to give the TakeMeHome, link as a way for that person to be able to order a kit. But we don't have the type of interaction which someone tells us they've been a contact.
Okay, and that question was from Pamela, and I just want to make sure, Pamela, if you can chat and make sure that that was for Jen, because I saw that come up later after Bryan started speaking. I just want to make sure that your answer was addressed to the right person, but I believe it was. Okay, the next question. Once patients are positive for syphilis, are they referred to a public health or primary physician?
Yeah, so I actually want to answer that more broadly, and I apologize that I didn't get into detail with that either. So I'm going to make sure I cover that. So in any kind of situation let me talk about the oral kits really quickly first, just to say that, with the HIV oral kit, they're going to get a preliminary result, and they are going to be then directed to get follow-up additional testing, right? And we actually try to make sure they essentially have 3 different sets of resources. So there's the resources that come with the OraQuick kit itself. As Bryan well knows, there's a 24/7 hotline. There's instructions for how, video instructions for how to use the kits. And then we have additional resources on our website. But one key part of our platform is that we create a localized resource page for every single partner, and they then get to determine, here's additional information we would like our users to see. So whether that's like where they would go for, if they did have a preliminary positive, additional access to STI testing or to PrEP, that's always included as well. In regards to the syphilis testing, I think the answer is sort of, again, related to all of the lab-based testing, which is, as I noted, there's medical oversight involved. And so each local jurisdiction kind of determines for their own protocols. So it may be that a navigator follows up and connects them to follow-up care, but we're certainly going to make sure that all the positives are identified and connected to offered services in terms of any kind of follow-up care that they might need.
Okay, thank you. I actually have a question for Bryan now, so you're off the hot seat.
Okay.
All right, so what % of time do program staff spend on ordering fulfillment on average? And then there's another question about hotline staff.
Yeah, I'm reading the
Okay, good.
question in the chat, and I'm so glad that this question came up because we're in the process of organizing a time and motion study to figure out exactly how long it would take, that it does take on average, to get a kit from, eligibility determination all the way through to the kits packaged and mailed. And my reasoning for wanting to pursue this has been like on my list of things to do for like 2 years, but I don't have the expertise to do it. We just hired an evaluator. So it's an exciting time. And my first task was this exact thing because this always comes up. And it's a little bit difficult to really get into without really getting into the weeds. I would say that depending on the number of requests that we get in, which for our program, on average, I would say at this point is about 5 to 10 requests a day. My piece, the eligibility piece that either myself or one of my backup, like my colleagues that also can do the same thing that I do, we're usually done within 30 to 45 minutes. I tend to try to knock it out first thing in the morning, and it's not a very labor intensive part of my day. The hotline staff, I think that this is the approach that we've taken of trying to separate responsibilities for the program across a couple of different teams, I think is meant to ensure that for every team that interacts with a piece of the program, they're spending a more or less negligible amount of time on it. And so it's not dominating their workday, just keeping track of their specific part of the program. As far as how many staff in total work on the program, I would say there's 2 ways to answer that. The first is that an average of 3 to 4 people will interact with one request in the course of processing it. It will be somebody doing eligibility, a hotline staff member making sure that the materials that are going to go out with the kit are assembled, and then someone in the mailroom packaging up that kit. Although the overall number of individuals who can do work on the program, there are 3 people who can do eligibility, 5 people who work in our hotline, and 2 people who work in our mailroom. So if we do, when we have had periods of really high demand, like in December, we sent out 400 kits in a month. It's like 4 times as many as we normally would do. It was it was really advantageous that we had that many people able to do it so that we could spread the work out across multiple people and make sure that still processing that many requests didn't dominate that entire workday.
Thank you. One more question, which is, are the GCCT kits urine only or are they 3-site? And how does follow-up treatment work?
We have both available. So the pilot program that we have with Binks, we purchased a certain quantity of 1-site boxes and a certain quantity of 3-site boxes. And then based on the client's risk behavior, they'll be recommended one or the other. Follow-up treatment. So one of the reasons that we pursued the pilot with Binks is because a major barrier for Virginia has been that we have not been able to identify an ordering clinician who would be willing to sign on for the entire state. And my understanding is the same is the case in Maryland. So Binks had the ability to have to assign an ordering provider, which has allowed the program to exist. As far as how follow-up treatment works, the lab is referred to the local health district in the client's county. So if it's somewhere in Virginia, it will be their local health district, or it'll be their county health department if it's in Maryland. And then just make sure I got this right. And then they have the option of pursuing treatment through the health department or through a private provider.
Thank you. And okay, Jen, there was just one more question about test costs. Is it $46 for all tests, or what is included in that price?
Yes. So the $46, that was referencing the OraQuick process, right? Again, sort of including all the components of that. In terms of the STI lab-based testing, that differs quite a bit depending on which package. The HIV dry blood spot only is about $55. And again, that includes, the postage in both directions, the kit, the fulfillment, the promotion, as well as the lab processing itself. With the comprehensive STI testing is in the range of $150. And we've done a bunch of kind of looking around to see if we could find it for less than that. But I think we haven't found much better than that. And if you do, please let me know. And then the prep monitoring is, I think, around 70 or 75. So that's how that's set up. But, we do have some, we won't charge for any labs that are not processed. And so we do everything we can to kind of keep those costs as low as possible.
Okay, and the final thing is a big thank you. And that's not just for me, that's from a person asking a question. Thank you to both of you. And the final question is, I believe you mentioned something about FDA clearance.
Did my audio freeze?
It looks like Janine might be having some technical difficulties, but I can read out the final question. It says, Bryan, I believe you mentioned something about FDA clearance for self-collection kits. Can you say a little bit more about that?
Honestly, I don't know that I can. I had, in the interest of trying to make sure that we had something in place for after our pilot with Binks was in place, I've just been talking a little bit with the folks in our STD prevention unit, and they let me know that they weren't sure what their ability to purchase more self-collection kits would be because of some kind of issue with, or let's say a lack of clarity on something pertaining to self-collection kits from the FDA. I don't know much more about it than that, except to say that my hope is that it gets resolved and that we can put an agreement in place with another company to continue providing self-collection kits for STDs, before we run out of our current supply.
Perfect. Thank you so much, Bryan. And it looks like that was our final question. So thank you all again. I put the webinar evaluation in the chat. So if our participants want to take 2 minutes to give us some feedback about how this presentation was and what you'd like to see in the future, we would be very grateful. But otherwise, I think that is it. Thank you all for attending today. And thank you so much to Jen and Bryan as well.
Thank you. Thanks for the opportunity to join you.
Thanks, everyone. Stay tuned for another presentation coming soon. Take care.
Bye, everybody.